the majority of diseases that you are going to encounter, no matter what your specific specialty is, because the pervasive diseases we're seeing all over the world right now are less related to what happens to us and more related to dysfunctional ways in which we live our own lives. In other words, what we do to ourselves. And instead of just using medication to treat something that happens to us, we are more and more being forced to partner with our patients to help them to change. We use medications, we use other things, but ultimately the patient takes responsibility for their own health, whereas before, with infections and that type of thing, physicians took charge. I am a metabolic health specialist with all those other degrees, and we offer a full service from the behavioral change all the way through to the surgery. But let's jump right into this and see where the world went wrong 50 to 70 years ago in terms of what we did. And there's a variety of influences that affected this. But ultimately, from a healthcare perspective, I'm going to minimize this. From a healthcare perspective, what happened is a directive at universities came down, certainly in North America, and I was working in Canada at the time, where we specifically shifted away from the science of physiology, and I love the fact that you have physiology in your title, in your name, because it's kind of a throwback here in the US. Physiology has become the poor stepsister of epidemiology, and everybody now is focused on epi. Well, science has shifted from physiology, which really explains methodology and cause, to outcomes-based observational epidemiology. And this has shifted our understanding of disease backward quite a bit. So just as an example, in the weight management space, what epidemiology says is, okay, you're heavy, you have a weight problem, any form of caloric reduction, any form, from the cookie diet to a vegan diet to a carnivore diet, and everything in between will absolutely observationally result in transient weight loss. No question about it. Appetite suppression, whether you're using phentermine or other medications, the big popular one right now are the GLP-1s, Ozempic, that kind of thing. There's new drugs coming on, the triple G, which is a GLP-1 and glucagon antagonist, several new incretin type drugs, all result in transient weight loss. But as a lot of the trials show, that weight loss is only transient. And in fact, I will tell you categorically that the most effective, overwhelmingly most effective intervention for weight loss is bariatric surgery. And with epidemiology, when people lose weight, the observation says that if you lose weight, your diabetes gets better. And if you treat the observed consequences and you change what you eat, how much you're eating, caloric reduction, you lose weight, and therefore bariatric surgery should improve diabetes. And I'm going to show you that data. That study has been done. But that's the epidemiology thinking. The way physiology works is we walk backwards. Okay, we've got an obese person or a diabetic person in front of us. How and why did they become obese? Why did they become metabolically unhealthy? And how do we treat the cause? And we now know from extensive physiologic research that the true transformation, the physiologic change that happens, is something we call insulin resistance, where cells put up a barrier, they phosphorylate the insulin receptor, and we become insulin resistant. And then genetically, that may be observed as people gaining weight or people having diabetes, and that is defined by genetics, as we'll explain in a few minutes. The problem is that most bariatric surgeons don't care, and they have no idea about insulin resistance or the physiology, because they do a surgery, people lose weight, their diabetes gets better. And what we've done as a society is we've fallen into a trap of blaming calories and a lack of exercise, a narrative promoted by Coca-Cola and other industries defending their products. And we have developed a mechanism called CICO, calories in, calories out, as a way to justify weight gain and weight loss. And in fact, if you look at a paper, now this paper was written in 2018, and it specifically states changes in glucose metabolism, hyperglycemia, and cardiovascular risk. So now more and more, we are associating cardiovascular risk not with lipids, but with changes in glucose metabolism and hyperglycemia. This paper still was an epidemiologic observational study over time, where they correlated an increase in caloric consumption, which is the green line over here, and you look from 1955 to 2015, an increase in caloric consumption from 1,800 to 2,600 calories on average, and it correlates directly with an increase in obesity and an increase in diabetes, but the two are slightly separate. However, I can tell you from a physiologic perspective that when you look at that caloric increase, that nearly 1,000 calorie increase per day, is that it is not made up of the other forms of calories. It is not we're eating more protein or we're eating more fat. It is specifically and exclusively a transition toward a much higher carbohydrate intake. So what has happened in the 1950s, about 70% of our caloric consumption was fat. And by 2024, 80% of the caloric consumption of the average human being, irrespective of where we are in the world, is sugar, it's glucose, it's carbohydrates. And that has been a massive shift, and all these diseases have trended according to that. So the case for bariatric surgery and the traditional epidemiologic thinking, erroneous thinking, I'm going to put that out there, is that excessive caloric consumption causes weight gain. We saw that in the previous graph. Obesity causes type 2 diabetes. And therefore, if you think logically about it, weight loss should resolve type 2 diabetes. And observationally, that is what happens. We do see that. But that doesn't explain the mechanism. So the overriding principle, as I've said earlier, is calories in, calories out, diet and exercise, a narrative pushed by Coca-Cola and other sugar-sweetened beverages. We're using now incretin medications to suppress appetite, and we see bariatric surgery as a final treatment. And if you look at this tree of health, you'll see that a high caloric diet and a lack of exercise observationally results in weight gain and obesity, and they then make the assumption that all of the metabolic diseases that you can see in the branches of the tree over there are a consequence of weight gain and obesity. Weight gain and obesity are causal to that. And I will tell you that the word causal is incorrect. So let's look at the genetics and the epigenetics of metabolic disease. Well, first and foremost, if you look at the blue circle over here, over time, if you think about an alcoholic is somebody who insidiously and unconsciously, slowly over time, shifted away from primarily drinking for the hydration value of water toward using alcohol, no longer for hydration, but using alcohol for its primary endorphin effect, and shifted away from drinking for hydration toward drinking primarily for emotion management, to manage anxiety, stress, depression, anger, fear, frustration, sadness, boredom, and pleasure, collectively called emotional tension. And an alcoholic is somebody that uses alcohol primarily toward emotion management, not hydration. So when an alcoholic says, oh my goodness, I'm thirsty, they're not saying they're dehydrated. They're saying, I'm having an emotional moment. I need a drug called alcohol to deal with that emotional tension. I need some whiskey. In exactly the same way. In exactly the same way. An obese person, a diabetic person, polycystic ovarian syndrome, all of those endpoint metabolic health issues are primarily occurring in folks who insidiously, maybe from even before they were born, when the mother did this as an emotion management tool while she was pregnant, but all the way through our lives, we have shifted away from eating food and in a pattern that is primarily geared toward healthy nutrition, biologically necessary substrates for our body, toward massively increasing in our diet a drug. Alcohol's a drug, but sugar and starch is a drug that has been inserted into our diet in massive proportions over the last 50 years. And as a society, we have shifted away from primarily eating for the nutritional value of food toward using excess sugar and starch, chronic excessive carbohydrate consumption, as well as a pattern of snacking. Snacking is the equivalent to smoking. Nobody smokes 20 cigarettes at one time. It's a cigarette here, a cigarette there to manage emotional tension. By the end of the day, we've smoked 20. Well, that is what a snack is. Healthy people, just like a healthy dog, will eat once or twice a day. But now we're eating 8, 10, 12 times a day, little bits here, little bits there, and it's always a carbohydrate. And then we binge eat. Because of the availability of food in most places in the world that wasn't there 50 years ago, where survival because of a lack of food was a problem. Now we have ubiquitous access to massive, massive amounts of food, primarily as carbohydrates, so we're binge eating. And those three things, carbohydrates, snacking, and binge eating, formulate a form of eating primarily for emotional restitution, not for nutritional advantage. If you never ever drank alcohol again, nothing bad would happen. Nobody dies of alcohol deficit. And in exactly the same way, if you never ever ate a carbohydrate again, nothing bad would happen as long as you had access to other food, because the liver makes enough sugar for the human body. So what happens physiologically is when we start to eat carbohydrates in a chronic excessive way and we start to eat multiple meals a day, all of that sugar goes up the portal vein to the liver. And the liver is the first place. First of all, the excess sugar can damage the intestine. And we see a number of inflammatory intestinal diseases, from gastroesophageal reflux disease all the way through to colon cancer. However, as that sugar enters the bloodstream, the first level of protection is in the liver. And the liver very rapidly converts that excess sugar to fat. Okay. And the fat that it produces is triglycerides. And triglycerides get transported in VLDL to the fat cells. So if you measure the lipids that are important in the body are not cholesterol and LDL. Those are fat transport molecules. The important cholesterol, or the important number in lipidology to look at if you want to see dysfunction, and it correlates directly with metabolic illness, is your triglyceride level. And ideally, a triglyceride level should be below 75 milligrams per deciliter. However, the liver turns that sugar into triglycerides, and that is the primary cause outside of alcohol of fatty liver disease. Fatty liver disease is not the consumption of fat. It is the conversion of sugar to fat by the liver to protect you from the damage of excess sugar. But some of that sugar spills over into the bloodstream. And now your blood sugar goes up, and insulin comes from the pancreas, and insulin's job is to shove the sugar into the cells where it can be stored and used as glycogen or glucose, or into the fat cells where, under the influence of certain hormones in the fat cells, we go through de novo lipogenesis, where we turn the sugar into fat and we gain weight. So at first, when you're eating excess sugar, you start to gain weight. However, that excess sugar in the cells begins to damage the cells. So they phosphorylate, they switch off the receptor to insulin. So insulin now can no longer have the effect of allowing sugar to enter the cells in which it works. We call that insulin resistance. And now we have two populations of patients. So at first, everybody gains some weight when they're eating excessive carbohydrate. However, we have two populations. Obviously, it's a bell curve. That's the blue line. One population, and this is where my personal biology is, we can produce genetically massive amounts of insulin. So despite the insulin resistance, we can override the insulin resistance by producing more insulin. We keep converting that sugar to fat. Our blood sugars are fairly normal, but we gain weight very, very easily. And we call that the obesogenic or the fat insulin resistance phenotype, where folks get obese very easily, but their blood sugars are normal. On the other hand, at some point, most people on this bell curve will reach a point where the insulin resistance exceeds their insulin production capacity. And those folks then are unable to turn that sugar into fat. So they're slightly overweight or heavier, but they then start to see a rise in blood sugar. And as that blood sugar rises over time, we can measure that by an increase in A1C, hemoglobin A1C, and those folks are called diabesogenic, where they are now unable to turn the sugar into fat. The sugar becomes the problem, and TOFI means thin on the outside, fat on the inside. Those folks that say, oh, look, I can eat anything I want to, I don't gain weight. Well, unless they measure their blood sugars are going through the roof, and those folks are diabesogenic. So in one population, they are primarily hyperinsulinemic with normoglycemia. On the other side, we have hyperglycemia patients with moderate hyperinsulinemia. The insulin levels are elevated, but their primary issue is elevated blood sugar. And if you look at those two populations, the disease spectrum is different because in the obesogenic people, their blood sugars are normal. They're not going to have heart attacks or strokes. They may have hypertension, but their primary issues are obesity with weight-related joint disease. But they're, because of insulin, and this is what insulin does, too high levels of insulin, dementia, Alzheimer's, cancer, because insulin is a cancer surveillance hormone, polycystic ovarian syndrome in females, and low testosterone, and autoimmune disease. Those are the diseases associated with hyperinsulinemia. And in those folks, bariatric surgery is a primary effect because they lose that weight. There are medications that have a primary effect, and the lifestyle interventions are somewhat secondary. On the flip side, the diabesogenic folks, they have vascular and interstitial elevations in blood sugar. What does that mean? Their primary disease is cardiovascular, and they are going to have atherosclerosis, increases in coronary artery calcium score. Plaque can be measured in their blood vessels. They are the folks that have ischemic strokes. And because of the nerves and the ligaments and tendons in their interstitial space, those are the folks that get neuropathy, neurometaplasia and arrhythmias, atrial fibrillation. They get fibromyalgia, they get inflammatory joint disease, and they develop DVTs and blood clots. So if you understand physiology, you can be much, much more specific about the biology, the genetics, and what the outcome metrics are going to be. And when you're managing these patients, this graphic is a crucial graphic to understand who your patients are. And if you measure the right blood work, you're going to be able to figure this out. So just to put this another way, on the left over here, you've got a normal person who's insulin sensitive with normal glycemia. The yellow dots are glucose, the green dots are insulin, and the red dots are ketones. So when you eat, you have sugar coming up, your insulin goes up, you shove the sugar into the cells, and your body stores it. Then between meals, when you don't eat for a period of time, your liver releases ketones. They become the primary fuel source. And if you look at these folks in the graph on the right over here, they're insulin sensitive. Both their intra and extracellular blood sugars are normal or low, but they're functioning fine with a mixture of ketones and glucose as a source of nutrition. Cellular nutrition. On the flip side, the diabesogenic folks have a lack of green dots. They have a lack of insulin. So all their sugar is on the outside in the bloodstream, causing damage to the vascular endothelium, but their cells are suffering from a lack of insulin, glucose, because they don't have adequate insulin. And those folks have extracellular hyperglycemia, but intracellular hypoglycemia. On the flip side, you have the obesogenic folks who have plenty of insulin. They can shovel that sugar into their cells. They have both intracellular and extracellular hyperglycemia, and they have insulin-resistant hyperinsulinemia. And these patterns are clearly recognized if you look for them. The problem is there's no teaching about this, or very little. We're starting to do this like this talk. So most people are unaware of this differentiation. And in fact, if you look at the population, you can see this fairly clearly. This guy over here is a guy called Bruce Fordyce, a South African ultra-distance runner, won something called the Comrades Marathon 9 times, just a brilliant ultra-distance runner. Look at him. He's running 20 miles a day, or 35, 40 kilometers a day is training, very, very lean. And he has type 2 diabetes. Why does he have type 2 diabetes? Because of carbohydrate loading, and he is diabesogenic. So his body takes that sugar, and even though he burns it off as fuel on his runs, the damage is done at ingestion. Exactly the same with this guy that most of you are going to recognize, Arnold Schwarzenegger. He ended up having to have valve replacement and cardiovascular surgery because he was consuming a lot of carbohydrate as his diet, maybe the steroids as well, but he was one of the sickest folks. And if you look over here, this is again Bruce Fordyce winning a run, and you cannot do an athletic event in most places in the world without the sponsorship being some form of sugar-sweetened beverage. So the narrative by industry is that you need sugar for energy and that you burn it off through the run. That's like telling somebody that you can go for that you can smoke 3 cigarettes, and if you go for a run, you can breathe out the nicotine. It's a ludicrous narrative, but that as a society is that we're victims of. On the flip side over here, these obese people have a very healthy non-diabetic profile because they've become obese. So their cardiovascular risk is low. And the healthiest person, if you look at this woman over here, most of her fat is in the lower half of her body. That's called lipedema. And she has the healthiest vascular profile of anybody in the obesity space. These two folks down here are physicians that work in the ketogenic space. This is Dr. Trokalajian in New York, big conversion himself. This is Dr. Jamie Seaman, who's a gynecologist who works primarily with polycystic ovarian disease, abnormal uterine bleeding, fibroid disease, all the damages of metabolic disease. Because the disease there is not obesity or diabetes, the disease is insulin resistance. Now, here's the biggest problem, I believe, misconception and mismanagement that has happened over the last 50 years because we've focused very heavily on lipids. When you look at that plaque in a patient's blood vessels, it is lipid, it is cholesterol, it is fat. As a surgeon, I've held that in my hands, but it is not there because the lipids are causing the problem. Sugar in a diabetic type patient or a hyperglycemic patient, just like nicotine, causes inflammation of the vascular lining. You form a blood clot, and the final layer of a blood clot, the patch or the healing system of the body, is to deposit lipid as a layer to smooth over the blood vessel. But if you've got a continuous hyperglycemic insult, you've got continuous inflammation, continuous deposition of lipid, but the lipid is the fireman, it is not the arsonist. The lipid is responding to the inflammation caused by sugar. It is not directly causing the damage. So when people focus on LDL and high cholesterol levels and try to manage that with statins, they are putting out they're destroying the fireman. They're not chasing the arsonist. And how do we know that? There's a friend of mine, David Diamond, that has looked at this in a study form. Obesogenic people with hyperglycemia have as high a cholesterol and LDL level as your hyperglycemic who's had a heart attack or a stroke. These folks over here, the hyperinsulinemics that can turn sugar into fat very easily, their coronary artery calcium score is usually 0 or close to 0. In other words, they have no plaque disease despite a very high LDL cholesterol and total cholesterol. Whereas the hyperglycemics who have high blood sugar, and you saw that in that very first graph, they have awful CAC scores, very high CAC scores, a lot of plaque in their blood vessels. They are prone to cardiovascular disease and stroke, but they have exactly the same LDL. Blood pressures are lower until very late in the hyperinsulinemics. And the key thing here, the key differentiator, is the hyperinsulinemics have an extremely low likelihood of diabetes, whereas the hyperglycemic is pretty much already diabetic. And it is so important to shift our thinking away from lipids as being the primary cause of cardiovascular disease toward this being a diabetes and a carbohydrate problem. Here's a Danish study that was published by cardiologists in Denmark, Gildenkern, and this was just October of 2023. They looked at 500,000 people in their population, studied them for 10 years, and they didn't look at LDL and cholesterol. They did, but that wasn't the primary marker. The primary marker of this study was incredible. It was the risk of a heart attack, the risk of a stroke, or the risk of a fatal heart attack or stroke. So you either died by heart attack or stroke, had a documented heart attack or a documented stroke. And they found that 10% of the population over 10 years had heart attacks or strokes. And they divided these patients into folks that had an A1C above 6.5 or an A1C below 6.5. Now, a normal A1C is 5.2, where you are not contributing to cardiovascular disease. So even in the normal group, some of them had slightly elevated A1C levels, hemoglobin A1C levels, and blood sugars. But the statistics here are incredible. First of all, 10% of the overall population had an event. But if you look both in women and men, if you look at those with hyperglycemia, their primary risk, where 5% of that population had their first heart attack or stroke, was in women 10 years earlier, a decade earlier than those who didn't have diabetes. And in men, there was a 12-year difference. And here's what's incredible, especially in the men. The first heart attack or stroke in a diabetic patient where 5% of people had a heart attack or a stroke if they had diabetes, was 43 years of age. 43. And if you didn't have diabetes, that number was 55, I think. So there was a 12-year gap between that. In women, it was 51 and 61. But a massive, massive change in the onset of cardiovascular disease based upon whether you were diabesogenic or obesogenic. Now, what was interesting about the study, it was done by cardiologists, so they didn't really want to look at this. And buried in the paper in supplement number 11, they showed the following data. So they took the same group of people and they divided them all into those that were on a statin and those that were not on a statin. And they had 72,000 people on a statin, 70,000 not on a statin, so a portion of the population. And they divided those patients into 10-year decade groups. And they looked at the risk of having a heart attack or a stroke, whether you are on a statin or not. And so this is results because we've been misled by the pharmaceutical companies about the absolute risk of cardiovascular disease on and off a statin. All the trials that proved statins were healthy were related to relative risk because there was no absolute risk reduction. And this study says exactly the same. So at every age group, there was absolutely no difference over 10 years between groups that were taking statins and those who were not taking statins in terms of heart attack or stroke risk. However, what's interesting, and even though it was not statistically significant, people over the age of 80 and people under the age of 40 had a 2.5 or 2.6 time increased risk of having a heart attack or a stroke if they were taking a statin. So if I told you there was no benefit to taking a statin with a 42% complication rate, what are you going to do? Think about that, okay? Because this is not a lipid problem, it's a carbohydrate problem. And I've made this comment right here, that statin therapy as a primary driver of cardiovascular care is likely to become obsolete within the next 1 to 2 decades. And the narrative is not going to be driven by physicians. The narrative is going to be driven by the pharmaceutical industry who drove us towards statins in the first place. And I'll explain to you why in a second. So, but let's back up a little bit and let's look at the physiologic truth. And this is the case for metabolic management. So if you look at physiology, the increase in measurable insulin resistance related to a high carbohydrate snacking binging diet, primarily for instant gratification of emotional need rather than nutritional need, chronic excessive carbohydrate consumption, snacking and binge eating causes insulin resistance. It's the body's response to defend itself against excess sugar. And therefore, therapeutic carbohydrate reduction, dietary carbohydrate reduction, together with a change in how you manage emotional tension, we call it effort-based instead of consumptive, as a way of life, as a transformation of who you are as a human being, as you define yourself so that you become the pianist, the exercise person, the spiritual person, rather than the carbohydrate person. Over time, a transition away from carbohydrates toward real food and changing your emotion management system restores insulin sensitivity. And that transformation, that biologic transformation, because it is a homeostatic hormonal feedback change, can take between 1 and 2 years. It's not something you do in a few weeks on a diet. But restoring insulin sensitivity treats obesity, type 2 diabetes, and every single one of the metabolic diseases caused either by hyperglycemia or hyperinsulinemia. And that is the way you help your patients to reverse metabolic disease. So the treatment here is a cognitive behavioral treatment and a nutritional change at a foundational level, not a calories in, calories out, exercise and caloric reduction diet. Along the way, just like if you're trying to quit smoking, Chantix may help you. Along the way, the incretin medications, the Ozempic, the GLP-1s, may assist that patient to sustain the behavior, but they don't do it for you, they do it with you. And in exactly the same way, if you're really struggling, but you're committed to the process, bariatric surgery may be used as a tool, not an endpoint along a journey of change, but it is, you cannot outsource this correction to a medication or to a surgery. So the truth, the physiologic truth lies in carbohydrate abuse, carbohydrate addiction, chronic excessive carbohydrate consumption for the purposes of emotion management rather than nutritional management. In the modern era, when somebody says, oh my goodness, I'm really hungry, it isn't because of nutritional deficit. They got plenty of food. It's primarily an expression of emotional need. Just like the alcoholic saying, I'm thirsty, I need a drink. And that's the part we want to correct. So as we correct that carbohydrate consumption, we correct hyperglycemia, we correct insulin resistance, and therefore all the metabolic diseases and then some that you see up in the tree over here, from preeclampsia, arthritis, migraines, autism spectrum disorder, yes, autism spectrum disorder, diabetes, irritable bowel, Crohn's disease, Hashimoto's, obesity, all of those improve or become more manageable. And here, for example, is the GLP-1s. And you've all used, you understand these, you see them all. But what doctors are doing more and more is they're prescribing the pill and off the patient goes and they lose weight. And it's wonderful because it suppresses appetite. But GLP-1 agonists increase insulin and reduce glucagon. So we change the insulin resistance management. GLP-1 is primarily a drug that helps, doesn't cause, but helps to restore insulin sensitivity. However, it should be used. In fact, I believe it's malpractice to prescribe a GLP-1 without helping the patient with a metabolic physician-supervised program, using a low carbohydrate diet, increasing your alternative emotion management strategies, whether that's physical activity, monitoring blood work changes, monitoring blood sugars and ketones, not lipids, and engaging in a cognitive behavioral multimodal health program. This is a substance abuse problem, not a calorie problem. So I love the GLP-1s. I think they're excellent because they treat insulin resistance, but as part of a journey, not as the journey. Same thing with bariatric surgery. A lot of my colleagues have resorted to more and more aggressive, ludicrous surgeries, such as the duodenal switch and the SADI, because yes, if you can't eat, if you sew your mouth to your anus, you're going to poop out all the calories, and you have caloric reduction, which is their mentality, and they will do malabsorptive and restrictive surgeries like a gastric bypass or a switch. I believe those operations should not be done in human beings. I believe those operations have no place in human beings because that is outsourcing your weight loss to a surgery without any behavioral change. And yes, you lose weight, but you don't necessarily get rid of all of those metabolic health issues. And they always come back at a time where you may not have gained the weight back and you are not aware of the fact that because you're eating mostly carbohydrates, but a smaller caloric amount, you still have the metabolic consequences, but it's not obvious because you look skinny. If you're going to do bariatric surgery, to my mind, it should primarily be sleeve gastrectomy. The lap band is kind of come and gone. We've got some intragastric balloons, but a sleeve gastrectomy together with a GLP-1 agonist is the ideal combination. However, the foundation should still be the metabolic behavioral change. Without that, these surgeries don't work long-term. And if you look at data from our practice, so this slide combines two setups. First of all, if you look at the green line, that is Ozempic. That's from the STEP 4 trial. So initially patients lost weight, but by a year when they stopped taking the medication, the rebound was enormous within 48 weeks. Less than a year of losing all that weight. Once these patients come off the GLP-1s, because they didn't have any behavioral change, they regain all their weight. It fails just like any other diet. The upper line over here is diet and exercise, where with weight loss, and exactly the same lines here with the diabetes. So these folks said, okay, weight loss, when we do weight loss surgery, we see an improvement in diabetes. So let's do bariatric surgery primarily in diabetics to see if we improve them. So the slide on the left over here is weight loss. And you can see traditional bariatric surgery, they looked at gastric bypass, they looked at sleeve gastrectomy, very similar weight loss results. But by 5 years, you'll already start to see an increase here. And by 10 years, 85% of the bariatric surgery population, irrespective of surgery type, have regained all their weight back. We see the failure of the GLP-1s long term, and we see the relative failure of conventional diet and exercise programs. The red line is my program. And the red line is using a combination, and not all of these patients had surgery, but a combination of primary foundational metabolic transition away from carbohydrates, what we just talked about a few minutes ago. We may, in some of these patients, use GLP-1s, and about 60% of these patients had surgery. And you can see our BMI decreased. If you look at the bottom here, average starting BMI in my practice was 41.3 in the obesogenic people, and by 5 years out, their average BMI was 27.7. A massive, statistically significant decrease, sustained over 5 years, and I can tell you, sustained over 10 to 15 years. We're just in the process of publishing this data. On the flip side, when we look at diabetics, and this slide looked at conventional medical management of diabetics. So for these folks, they were able to drop their A1C medical therapy from a hemoglobin A1C of 8.8, knowing that a normal A1C is 5.2, dropping that from 8.8 down to 8.5 at 5 years, basically no difference. And that is the standard glycemic index control with medications, with all the diabetic medications, really pathetically poor. Because remember, your complications occur, the higher your A1C, the worse the complications. They then did the experimental, and this is the publication by Schauer, the Stampede trial, where they did bariatric surgery, sleeve bypass, same kind of result. They saw an initial drop of A1C from 9.3 down to 6.4 within a year. There's a caloric restriction. That's the epidemiologic result. But then an insidious creep up of the A1C, and it really stabilized at around 7.3, still profoundly diabetic, better than traditional therapy. And if you just look at those two, well, kumbaya, it looks good. Green line is GLP-1 therapy as a primary exclusive intervention. In our practice, and this is our type 2 diabetes data, if anybody ever tells you you cannot get type 2 diabetes into remission, you absolutely can. And these patients went from an average A1C in my practice of 8.9%, 5 years out, average A1C was 5.4%, off medication except perhaps metformin. So think about that. We are able to put type 2 diabetes into remission with a program that reduces carbohydrate consumption. And certainly in the part of the world where you guys live, India, Malaysia, that's Southeast Asia, there is a massive diabetes problem, far more so even than the obesity problem. And look at these results, better than anything else that can be achieved by endocrinologists or even surgeons or the drug manufacturers. And this is sustainable over 5 years and longer. From a blood work perspective, this is an anecdote. This is a guy called Archie, a young kid that we operated on. BMI at the beginning was 86.7. He was 15 years old at this time. We did surgery on him. He engaged. He wholeheartedly, absolutely transformed his diet. Went almost pure carnivore, really eating no carbohydrates. And over the course of just 2 years, now he's a big guy at 86.7, dropped his BMI from 86 to 33. Massive improvement. Look at his triglycerides. Starting triglycerides, 766. Subsequent triglycerides, 94. LDL went up. Why? Because he's eating fat, and that's perfectly healthy. Zero CAC score, no plaque in his blood vessels, and I think that LDL in my practice is wonderful because his triglycerides are low. A1C, he'd already crossed over, even though he's obesogenic, had crossed over. A1C was 6.7 when we first started. Within 2 years, he was down at 5.5. Fasting blood sugar from 166 to 88. C-peptide, massive amounts of insulin production, 47 units of insulin just to keep his blood sugar around 166. Now he's at 7.9 units of insulin in his bloodstream to keep his blood sugar at 88. So massive improvement in all of his markers because, not just because of the surgery, but because he changed his diet. So our management program is geared toward not just losing weight or improving diabetes, but it is to sustain it lifelong. And the only way you can sustain this is to change the foundational aspect of your behavioral health. This is a behavioral problem. It is fundamental to who we are as human beings. You don't drink alcohol, you are an alcoholic. You don't use heroin, you're a heroin addict. You're a crackhead, you're a smoker. The addiction defines us. You are fat, you are diabetic. That defines us. And it's transformation in terms of the fundamental strategies we use to manage emotional need that is required. It's much harder, it takes longer, but it really works. And the single therapy evidence, if you look at monotherapies, if you use lifestyle intervention, just the standard calories in, calories out, most folks after 2 years can sustain about a 5% body weight if they're lucky. Most people fail the diets. When you look at the Step 4 Ozempic trial, this is a published trial. In that trial, they used the GLP-1s for 10 years. For 1 year, we saw a 10.6% body weight loss, total body weight loss, a good weight loss. In fact, you see up to 70 to 20% with Mounjaro. But within 48 weeks, they'd regained 69% of their weight. So by the end of a year, the 96% of patients on the Ozempic trial had regained their starting weight that they lost when they went onto a placebo. With bariatric surgery, we get up to a 50% weight loss initially, but by 10 years, 85% have regained some or all of that weight back. And that starts insidiously after 2 to 3 years. The sequential therapy of nutritional dietary medication, modification, cognitive behavioral therapy, and then pharmacotherapy and bariatric surgery, as indicated if people are struggling as a tool to help them, results in the results we just showed you, which is sustainable long-term weight loss and improvement in metabolic treatment. So really what we're looking for is a conversion back to insulin sensitivity, which is the best way to manage patients with metabolic disease. And bariatric surgery may be a final step, and it may be a key component for some people, but it is not necessary if you're able to do the conversion by yourself. These are some of the results we see. These are some of the benefits of this multimodal therapy. And these are all patients of mine who are at least 5 years out from their procedure. So this is sustainable. And you can also see the improvement in the metabolic health. So in conclusion, we really have to, and this is what I like about the word in the name of who you are. We really have to begin to abandon epidemiology and return back to a physiologic understanding of disease process if we are truly going to treat root cause. However, human metabolism is always, always, always physiologically driven. And you cannot become obese or diabetic without creating a sustainable place of insulin resistance where the body is trying to defend you from the damage of sugar. And as it breaks down, you either become fat or diabetic or both. So obesity and diabetes means that you're insulin resistant, and also means that that person has lost the capacity to control their relationship with sugar and starch. So trying to control it through some diet, low-carb diet, is not going to work without the ancillary behavioral modification. Chronic excessive carbohydrate abuse, carbohydrate addiction, not global caloric consumption, primarily causes insulin resistance. The human body's hormonal response defensive mechanism to chronic excessive carbohydrate consumption is genetically predetermined and results in either the obesogenic or the diabesogenic pattern with consequential metabolic diseases that are associated but different for each category. Metabolic disease depends on when hyperinsulinemia peaks. Obesogenic, massive insulin production. Diabesogenic peaks at a much lower insulin level. Bariatric surgery results in weight loss, but does not treat the root cause of obesity. It has to be an integrated program. Treating insulin resistance by multimodal means treats the root cause together with or in lieu of bariatric surgery. And fat-adapted insulin sensitivity is the healthiest hormonal state, which allows you to live long and be healthy with that sustainable life state. I do go by the Carb Addiction Doc on Instagram, on YouTube. I've got a lot of videos on YouTube if you desire to follow me. But my job today is not for you to agree or disagree with me. My job today is for you to learn to think differently and question everything until you are satisfied with the answer. Thank you so much.
Well, thanks for that, Rob. I think your last statement was very impactful. For people to be able to think whether what they're doing is right, whether what they're being taught is right, and just a couple more sentences before I pass it to Huzaini to carry on the quiz, is that from what you said, and from what in the low carb space that I've been involved in, it's all about educating doctors, educating people, all healthcare professionals, educating students, medical students, and other students, and educating the public to understand. So it's about.
There's one additive to that. Whether my patients agree or disagree, do the experiment just for a short period of time. Take 3 months, take 90 days, and do the experiment. And it's amazing how the most resistant patients prove to themselves that this works. They lose weight, all those illnesses begin to get better. So yes, education is important, but ask your patients, the most resistant ones, the most skeptical ones, do the experiment.
Right. Thanks, Rob. Over to you, Huzaini. Now we'll come back to the questions.
Okay, Prof. Thank you again, Dr. Rob Cywes. So I hope everyone has been paying attention. As now comes the quiz competition. Although exclusively for students to win the prize, everyone is invited to try and register to play this game. So it's a different format than the pre-test. So I'll be running the quiz as we go from one question to another. So please go to quizzes.com, or let me see whether I can share a QR code. I don't think I can. Some people have been inside. So students, if you do want to win the prize, please enter using your student ID. Okay, thank you. I'll wait for a couple of minutes before I start the quiz. In the meantime, those who are not interested in the quiz can start to come up with questions for Dr. Rob Cywes to try and answer after this quiz session. Thank you.
Yeah, there are already a few in the Q&A box. When you start the quiz, is that all right, Zaimi?
Sorry, Prof. You broke up a little bit. What?
Not stable. I just said that when do we go to the questions? After you have started the quiz?
Yes, Prof.
All right, just let me know.
Okay. So I'll wait for another minute before I start the quiz. So students who are interested to win the prize, quickly join the quiz, please. Because once the quiz starts, you can't join in the middle. You have to be registered to start from the beginning. Okay, seems there's only about 18 participants, but plenty of students as I can see here. So I'll just start the quiz now. You can refer to your own devices as well.
And so we can start the question and answer, yeah? We can start the question and answer.
Okay, I can stop the sharing now. Okay, Prof,
All right,
you're on.
Yeah, Thank you, thank you. Thank you for those of you who asked questions. We've got quite a number of questions here. I'm not sure whether we'll be able to go through all, but the first one reads as, by Hamad, reads as, what's the limit of reducing carbohydrate in our diet as a preventive measure?
I think with any addiction response, the first step is ownership that it's a problem. And once, instead of valuing carbohydrates, you begin to realize that they are causing you health issues, or they are a liability to improving your health, even if you don't have tangible disease, if you're a young person, you begin sequentially by reducing them. So you may say, okay, I love my rice, but I'm okay not eating pasta. I'm okay cutting out the potatoes, and maybe fruit isn't that important for me, or I'm not going to eat fast food, I'm going to eat real food. So you do this in a progressive, sequential way. And slowly over time, as your body gets used to consuming more, whether you're mostly on the vegetarian side, I don't mind if you're on a vegetarian side, but you want to convert from being a white vegetarian to a green vegetarian. In other words, a lot of vegetarians with obesity and diabetes eat primarily the white foods, the rice, the potatoes, the breads, the grain products. And if you shift more to a vegetarian diet that is green-based, that is plant-based rather than starch-based, you already begin to see the improvements. I've got some patients who are pure carnivores, absolutely fine, but it's a transition. And slowly over time, over the course of time, you reduce the carbohydrates by category. And eventually you get to a point where you are hardly eating carbohydrates. Now, the caveat is all vegetables by definition are carbohydrate, they're cellulose. But the human intestine has lost the capacity, like a cow or a gorilla, to process cellulose. We've lost that symbiotic relationship with bacteria. So we do not count carbohydrate content of vegetables other than rice, grains, and potatoes. I've never met somebody who had a really bad day and rushed home to pig out on Brussels sprouts. So on a vegetarian diet, we have a lot of Indian patients, Hindu patients who, in this in East India, I've got a lot of patients who have diabetes. And if we can shift them away from the traditional starches, and my friend Jason Fung also introduced the concept of intermittent fasting, where while you may be still eating some carbohydrate, you're going a long period of time where your body is using what you've eaten rather than continuously being in storage mode. It now spends a lot of time in utilization mode. And both of those concepts, whether you start with intermittent fasting, start with the carbohydrate reduction, both of those are stepwise processes toward eliminating the carbohydrates. And the promise fulfills itself. As you start to get healthier and better, you find it easier and easier to remove other categories, but you don't start by jumping in the deep end of this pool. And that's why it's a metabolic transition. So eventually the goal is to really not be consuming any non-vegetable carbohydrates. But you don't start there, you progress to that.
There's another question on artificial sweeteners, Rob. What do you think of artificial sweeteners?
Absolutely fine. So I'm currently, if you look over here, I'm currently wearing a CGM. I'm not diabetic, but this is the Dexcom G7, and it gives me a blood sugar reading every 5 minutes. And I can assure you, despite what you may see on the literature, that artificial sweeteners do not cause a rise in insulin, and they do not cause a rise in blood sugar. However, there are two populations. So artificial sweeteners are a very, very useful way to manage carbohydrate, that sweet taste, that desire, without causing harm from carbohydrates. But there are two populations. The first population, my wife is one of these, who finds that by using artificial sweeteners, it prevents her from eating the real thing, eating the real sugar. So if she drinks, for example, a diet soda or bakes with an artificial sweetener, it prevents her from the real thing. I, on the other hand, find that it's a trigger for me to, it's not about the artificial sweeteners. They're absolutely fine in terms of diabetes management. But for me, when I taste something sweet, up here, psychologically, it triggers me to desire that. So my coffee, I went from 4 spoons of sugar in my coffee to bitter coffee. My wife, on the other hand, has Splendid in the coffee. So you've got to look at yourself and say, is this a trigger for me, or is it a way to prevent me from doing the right thing? But do not think that the artificial sweeteners in any way, shape, or form make diabetes worse. That's a false narrative. So you've got to decide, does it trigger you or not? But it's a very, very useful tool to replace the sweetness from sugar with the same sweetness without the carbohydrate consequence.
Thanks, Rob. Interesting question from Dr. Andrew. He says he's a practitioner who uses low-carb diet and intermittent fasting to help patients reverse diabetes. And he's found that it's more difficult to reverse a skinny diabetic as compared to a fat diabetic. Can you shed some light here? Absolutely, because the fat diabetic is really not diabetic. They're a crossover. They are primarily obesogenic, as we explained, but even though they can produce very high levels of insulin, you can measure insulin C-peptide, their resistance, because of their chronic excessive carbohydrate consumption, has reached a peak where insulin can no longer do that. So as they come off the carbohydrates, they restore non-hyperglycemic insulin resistance. So they downgrade from diabetes to just being obesogenic, and then the weight loss is the next part. So they can produce massive amounts of insulin. They don't need ancillary drugs. As long as they cut back on the carbohydrates or begin to reduce them, they get better. Whereas the TOFIs, the thin on the outside, fat on the inside, the skinny diabetics who cannot produce a lot of insulin, they're almost behaving like a type 1. They do not have a very high insulin production capacity. So you really have to take much, much longer and be more fastidious in those patients to get them to that point. And that's where you are primarily treating the insulin resistance with additive insulin. So in those patients, in my pure, I know they're type 2 because I know they produce insulin. By the way, always check and make sure that those patients don't have antibodies to insulin, because a significant cohort of my TOFIs have a disease called LADA, L-A-D-A, latent autoimmune diabetes of adulthood, which is antibody mediated. You need to check the GAD65, the insulin autoantibody 1 and 2. I always do that. And we often pick up folks who produce insulin, but they have antibodies against insulin. So you want to exclude that. But the pure type 2 TOFIs, that is where, here's the paradox. We have to increase their diabetic medication to reduce their blood sugar. If I've got a few minutes, I'll explain to you kind of the fact that the current endocrinologists, the way they treat diabetes, they are the biggest enemy of their diabetics. And here's why. I did my PhD with a guy called David Jenkins in the 1990s. In 1981, David Jenkins in Canada, in Toronto, wrote the paper that began the glycemic index. So in the 1980s, we didn't have accurate blood sugar management, blood sugar number checking. We had very, very poor ways to measure blood sugar accurately. We had a little sliding glucometer. We only had porcine and bovine insulin. We didn't have good insulins. And the fear at that time was unrecognized hypoglycemia. So David Jenkins created the glycemic index, where we create a mathematical formula based upon what different types of carbohydrates do to your blood sugar. And then the management style was to treat the diet rather than to treat the blood sugar, because we didn't know what the blood sugar was. Well, so they tolerated hyperglycemia because of the intolerance of hypoglycemia. And it's hyperglycemia, that chronically high levels of blood sugar, that cause the problem. In the modern era, we have great monitoring devices. I know what my blood sugar is every 5 minutes. We have excellent insulins. We have Humalog. We have a variety of long-acting insulins, Tresiba, Lantus, Levemir, excellent insulins. And because we can monitor our blood sugars, we no longer have to fear lows. The correct approach to diabetes management is to directly treat the blood sugar irrespective of cause. So in the glycemic index model, they control the diet, they control the insulin, and the diet fluctuates. In my practice, the diet is consistent, and we vary the insulin amount that we give our patients exactly the same way that my pancreas does. And in that way, we can tightly control glycemia without going low. Why am I talking about insulin? Because in the type 2s, the first step is to go up on your medication while they remove carbohydrates to bring the blood sugar down so that we overcome insulin resistance. Remember, in the type 2s, it's a lack of insulin that's the problem. The reason the obese person is not diabetic is because they can produce high levels of insulin. So Jason Fung, my good friend Jason Fung, has the old
the suitcase is too full model, but you have to go up to come down. As you go up on the insulin, as you restore normoglycemia, the cells then dephosphorylate the receptors. So you can progressively become insulin sensitive, and then over time you can lower the insulin dose. But the goal here is primarily to correct hyperglycemia and then begin to withdraw the medication. And it's a different strategy depending on the obesogenic versus the diabesogenic person. But we have to change our thinking. In fact, that report that we're publishing is going to publish that methodology that we're using.
Thanks, Rob. I think that's, Hussaini, how are we doing with time?
We are okay. We've got maybe another 5 minutes.
How many more minutes? Sorry?
5 minutes.
5, okay. So, Rob, I think that this question is on carb addiction, because it states here, how do we help patients who feel agitated and difficulty in focusing when they cut down the sugar or carbs?
So are you talking about educated people who still have an addiction?
The question, sorry, come again?
I just want to rephrase the question. I'm not sure I quite understand the question.
The question is how to help patients if they feel more agitated or have difficulty in focusing when they cut down sugar carbs.
Yeah, I think the speed is the issue. You know, typically most of us have done diets. In fact, most of my patients are experts at failing weight loss programs or diet programs. And a diet is, here's your diet, you start tomorrow and you go all in. You jump into the deep end of the swimming pool. Physiologically, the body can't do that. So if you think about smoking, the first step when you quit smoking is there's a physiologic response. The body needs nicotine, and your nicotine levels are fluctuating, and you're miserable when those levels go down. And then after about 2 weeks, the nicotine is washed out of your system. Then you're primarily dealing with a psychologic dependency on smoking as an emotion management tool, but your physiologic dependence on nicotine is broken. Exactly the same way, except it's more intense and longer. So when you're eating carbohydrates, your blood sugars are fluctuating up and down all the time. And that's measurable. Every time your blood sugar goes down, you feel miserable. You feel agitated, you feel hungry. There's a tremendous drive by the body toward consumption of carbohydrates. And if you suddenly cut them out, we talk about the keto flu, keto agitation. It's a miserable withdrawal. Almost like a heroin addict. If you lock them in a room, they go through all the shakes, alcohol. Every drug addiction has the same problem. However, if you slowly change that by category, as you get this high amplitude reduction, where the amplitude of your blood sugar flattens out over time, and you replace, and this is the fundamental foundation of our program, you replace their sources of emotional restitution with physical activity, human connection, creative art, spirituality, meditation. You improve their sleep as they find other forms of emotional outlet. And the blood sugar doesn't suddenly crash down, but it slowly flattens out. As they get into that ketogenic space over the course of a few months or a few weeks, you don't get that effect. The speed by which people quit eating carbohydrates is the problem. And if you understand that this is something, your obesity or diabetes took decades to occur, you're not going to fix this in a day. It takes on average 2 years, 18 months to 2 years to restore insulin sensitivity. But if you take 100 and you subtract your current age from 100, that's how long this process should last. So if it's 50, 60, 80 years, who cares about 1 or 2 years? We don't want those results in a few weeks. Now, within a few weeks, you're going to start to see improvement. I had a patient last week who started this process, had terrible sinusitis from acid reflux related to GLP-1 and carbohydrates. Within a week, his sinusitis cleared up. But then progressively over time, the other things get better. So I think the key strategy here is not to do this suddenly and all at once, but to categorize and work with a dietitian to slowly remove and replace categories.
Thanks, Rob. There are a couple of questions here about the percentage of carb intake.
Right. So initially, right.
So I just want to
yeah. So initially, the objective here is to transform the primary fuel source that your body's cells use away from sugar toward fat. And in order to do that early on, in what I call there's two phases, the therapeutic phase and the sustainability phase. The therapeutic phase, where you are correcting disease, correcting insulin resistance, correcting your body's dependency on sugar, the cells that can use ketones or sugar, you want to be, over time, you want to get very, very low on your carbohydrate consumption, as close to zero as you can. Once you reach that inflection point, where your body is not only in ketosis, but fat adapted, where the cells, when they're offered sugar or fat, prefer ketones and fat. Remember this, that 80% of everybody's energy utilization is actually non-esterified fatty acids, whether you're diabetic or not. Only about 20% of the caloric utilization by the body is either ketones or glucose. So that 20% we're playing with, not the full 100. 80% is always non-esterified fatty acids. That's why LDL exists. LDL transports that fat. That's why it doesn't matter if LDL is high. However, as you convert your body across to being fat adapted, that early process, which can take a few months up to 2 years, depending on how severe it is, that once you want to end up with ultra low carbohydrate consumption. We use below 30 grams of non-vegetable total carbohydrates a day, but it is not a diet where you eat up to the 30. It's not, I've only eaten 10, I can have this cookie, because psychologically, the alcoholic's not going to have a one beer because it doesn't make them drunk. It's the concept of not eating those things that's more important than the absolute gram numbers. Then down the road, and there was a beautiful paper recently published by a woman by the name of Isabella Cooper out of the UK, where she took a group of women who had all been in fat-adapted ketosis for more than 4 years. And they were eating 50, 75, 100 grams of carbohydrates, but they were always in ketosis. You know, one of the things that we do, it's right on here on my desk, but this is Keto Mojo. You can manage, you can monitor your ketone levels. I mean, I'm sitting at my desk right now. This is right on my desk because I check my own numbers on a regular basis. And you can use that to monitor ketosis. Once you're fat adapted, you're in ketosis no matter what. And even when you have a little bit of a carbohydrate relapse, if it's short duration, it doesn't matter. You restore it very quickly. That's what Isabella's paper said. But it takes time to get there. So in the therapeutic component, ultra low in carbohydrate, because it speeds up the restoration of ketosis and fat adaptation. And once your cells hormonally adapt to fat, and what do I mean by fat adaptation? Homeostasis. Once or twice a day, if you're eating 2 meals a day, you should have a surge during that meal of insulin, testosterone, thyroid hormone, and human growth hormone. Those are your anabolic hormones to store and reprocess the food you've just eaten. Then there should be a significant decline as you flip into glucagon-dominant fat utilization, where glucagon is the dominant hormone, causing autophagy, cellular repair, and using fat as your fuel source. And throughout the day, you're fluctuating between a brief period of insulin dominance, a long period of glucagon dominance, and then another period of insulin dominance. In the insulin-resistant person, insulin is dominant 24 hours a day, and there's no fluctuation. So fat utilization is really about the restoration of glucagon and insulin as equal and opposite hormones that restore metabolic health. That's what fat adaptation is, and that's measurable. And when you're in ketosis, you're glucagon dominant if the ketones are coming from your own fat cells. You can drink a bottle of olive oil and be in ketosis, but that doesn't help you. So it's about the restoration of that metabolic health. And then you can actually eat a little bit of carbohydrate to trigger insulin once or twice a day. And so, for example, my son, he's about a 95% carnivore, he's 3 years old, but he gets a bottle of milk twice a day to trigger that insulin response. But he's always in ketosis. So it's a transitional thing. It's not just an absolute one-day thing. There's a transition from the therapeutic phase to the sustainability phase.
Prof, sorry, there's a question from the floor.
Sure.
You mean the last one, Master Carb Sinke?
No, I think that somebody raised their hand.
They just have to unmute themselves.
Yes, please unmute yourself,
Okay,
Asmeda.
Asmeda. Yeah, go ahead.
Asmeda's muted.
Asmeda, you're on mute. You raised your hand. Do you have a question?
Yes. Maybe we can go through the Q&A, the last question, bro.
Yeah, the last question is also about carb restriction and how much of carbs must you not take in order to restore insulin sensitivity. But I think you've already answered the question.
Yeah, I think that it's a continuum over time.
Okay. Asmeda, you can
the
still.
The only other statement is converting your thinking away from this being a lipid problem to this being a glucose and a hyperglycemia problem. And the evidence is very, very powerful. And as the drug companies roll out the GLP-1s and make enormous profits, they're going to sacrifice statins, which are difficult to defend, for GLP-1s. And the pharmaceutical companies are going to drive this narrative, not the physicians.
Right. So, so can I wrap up the session and you're going to, are you ready with the quiz?
Yes, yes, I'm ready with the results. Yes.
Yeah, but before we go to that, I'd really like to thank Dr. Rob Cywes. I think there are a lot of gems that you told us, and a lot of you're leaving us with a lot of thoughts, I'm sure, and with the students here, and I saw some dietitians here, and there was actually another question which I skipped that asked about a balanced diet. What do we do with balanced diets if we're cutting carbs? But I think in your narration and your
I hate the word balance. You know, ask an alcoholic to balance their diet or to balance their drinking. I think the important thing, and this is a conceptual change, there's nothing wrong with eating carbohydrates. Carbohydrates are absolutely fine. In fact, we exist as a species because of carbohydrates during lean times. However, in an era of abundance, we don't have to eat carbohydrates because we've got all the other food available to us. Number one. Number two is that it is never about carbohydrates. It is about our relationship with them. Alcoholism is not about alcohol. I drink alcohol. I've even been drunk from time to time, but I have a good relationship with alcohol and I've got boundaries. If you've had 5 DUIs and you've got liver disease, that relationship is broken. If you're obese, if you're a type 2 diabetic, that is my definition of the relationship being broken. And we fall into the addiction trap of validating, justifying, minimizing, trivializing the harm to give ourselves permission to do this. I know I just had a stroke, but for this valid reason, I need to eat this ice cream. So understanding that the concept of balance or a general diet, which the dietitians favor very heavily, is reasonable. But if you're going to do that, approach it from the concept that the human biology primarily uses fat as its primary fuel source. The cells physiologically of the human body do best when they're under the influence of fat. And it's prior to 1950, fat was a dominant part of our diet. But because of the scare of cardiovascular disease from nicotine and the shift of emphasis not against cigarettes, that, oh, cigarettes are fine, you're clogging your blood vessels because you're eating too much fat. The error occurred in the late 1950s and 60s when we became lipophobic as a society because we blamed saturated fat in our diet for cardiovascular disease to deflect against the harm that smoking does. It took us 30 or 40 years to realize that smoking causes cardiovascular disease, but by that time we were entrenched with lipophobia. And every dietitian out there that's practicing grew up and was trained in the lipophobic era. I'll give you an example, okay? When you talk about balanced diet, everybody now says constipation, gut health, fiber, fiber, fiber. How much fiber is there in breast milk? 0. And babies don't explode because they can't poop. Breast milk has the highest saturated fat content of any food out there, and everybody will tell you breast milk is excellent. So we take our kids off very high saturated fat breast milk with no fiber in it, and we put them on Cheerios and cereal and high grain stuff. What are we doing to these kids? The brain is primarily fat. And when you reduce the fat in the diet and you make fat from sugar, it's a very poor form of fat. Well, the brain is developing for the first 5 years of a child's life. The white matter of the brain is 65, 70% fat, and it requires fat from fat stores, 3 omega fatty acids, 6 omega fatty acids. If there's a deficiency of adequate dietary fat, the brain doesn't develop normally structurally. And we've seen autism spectrum disorder go from 1 in 15,000 in 1970 in the US to 1 in 34 children in the US in 2022 has autism spectrum disorder. And it's not a vaccine issue. It's not a genetic mutation issue. It's a substrate issue. Too much sugar and too little fat in the mother's diet, and then formula, breast milk formula. It's baby milkshakes. So if you look at the word balance in a dietitian, that word no longer exists in a diet where we have ubiquitous access. Most of you currently are sitting within 50 meters of an abundance of food. Think about that. Whereas 100 years ago, food was scarce and we had to go out and forage for it for the most part. But the human body is designed to deal with food scarcity. It is very poorly equipped to deal with food abundance. And the consequences are our metabolic disease.
Thanks, Rob. Hussaini, just one last question. I think this question was asked earlier, and I think someone really wants to know, Rob, whether you would do, or is it permissible or encouraged to do a bariatric surgery for children with Prader-Willi syndrome, and whether there are any complications to doing it in such young children?
So Prader-Willi syndrome is interesting in that we believed it to be a genetic issue of hyperphagia, where the kids just can't stop eating. But the reality is, when you look at the Prader-Willi population, it's not that they can't stop eating. It's that they can't stop eating carbohydrates. So when you take that early child, and let's face it, most of these kids under the age of 12, 14 don't jump in the car and go down to the shop to buy sugar and starch. So if the house changes and they remove the carbohydrates, that hyperphagia, that continuous eating goes away. It's more part of the endorphin system of the brain than it is hyperphagia specifically. So with those patients, the ideal, now I'm a pediatric surgeon, I've got several of them in my practice, the ideal thing for those patients is to remove carbohydrates from the environment. You know, you can't have cigarettes in your pocket and say, I'm going to quit smoking. You got to crumple them up and throw them away. And you're not depriving your child of the pleasure of carbohydrates by not having them there. My son has not suffered because he's never eaten a carbohydrate. He doesn't know what they are. So the first step is to remove the carbohydrates. And then the greatest change in the last 5 to 7 years, and I've been doing this for almost 8 years, since the old Victoza days, but to use a GLP-1 agonist in those patients, because genetically, at least biologically, they are going to modify their carbohydrate consumption, because every time they eat that, if they have access to it, they feel terrible. And they automatically at a subconscious level change. So the GLP-1 agonists are a huge tool to these patients. But absolutely, to do a bariatric surgery on a Prader-Willi patient is okay as a last resort. However, exclusively under the conditions that you remove carbohydrates from the environment. Because the hyperphagia is going to destroy the surgery or make the surgery non-effective, not because the surgery didn't work or the surgery wasn't safe, but because we just reduced caloric consumption. So for the majority of these kids, if they're young enough, you don't need surgery. But if you do, it is absolutely necessary, more so in this population than any, to get rid of the carbohydrates.
Thanks, Rob. I think we'll come to the end of Q&A session. I'm sure there are a lot more questions. I know I have, but it's getting a bit late. And go ahead, over to you. Thanks again, Rob. Thanks so much. We really appreciate it. And I saw some comments saying that it was a very impactful talk and they learned a lot. So thank you for that.
Thank you. And if anybody has any additional, if anybody has any additional questions, I've got a YouTube channel called Carb Addiction Doc. And if you go into the comments section, I always read the comments and I'll answer those questions if you want to.
Okay. Thank you, Dr. Rob, and thank you, Prof. Nafiza. So we had the quiz competition. The class accuracy is about 20% only. The questions were very tough, Dr. Rob. But we managed to get a few winners here. Dr. Andrew Chu, you're the top scorer, but unfortunately we can't award the prize to you. So please give a round of applause to student with student ID 2022-813392 for getting first place. 2023-261-396 second place, and 2022-622-032 third place. So if I can get these people, these students, to raise their hands, please, and I can let you share the stage with the speakers, Dr. Rob, with Prof. Nafiza, as well as myself. Let me just stop sharing. So 2022-813392, 2023-261-396, and 2022-622-032. Okay, I see Khalida Sofia there. Diana and Ikmal Arfizal. I've got an extra hand up. I hope I'm giving the stage to the right people. Can the three that has been given access to the stage please switch on your video so that we can take a picture? Students, if you don't mind.
Is everyone shy?
Maybe they weren't ready, Prof.
Yeah,
How
perhaps.
to switch on the
How to switch
video?
on the video? Maybe you have
Let
you
me
have
see.
blocked them from switching on the video.
You don't see the button for the video, because once I give you the I think you can hold on. Video.
Yes, some are not ready.
Which session? Actually, I have no idea as well, because I thought once I give you the stage.
It's okay. We'll just take their picture, a picture with their names here.
Yeah. Okay. All right. Let me take a picture. Give me a minute. Okay. Big smiles, everyone. And now it's not coming out. Yeah. Okay. Big smile. Okay. Pictures taken. Okay. With that, I think we can end the session. Prof, back to you.
Yeah. Yeah, we can. Rob, there are some requests for the recording. Are you all right if you give it to the participants?
Absolutely fine. The more we share, it's information that I believe needs to infiltrate in our community. So absolutely, do what you want to with the information.
All right. Thank you so much. Thank you again, Rob. Have a great day.
You're welcome. Thank you very much for having me. And I
us.
love the progressive nature of everything. It's great. Thank you.
Thank you.
Thank you.
Bye, everyone.
Bye.